bursa, as the name suggests. Okay, so something I've just cut now. Okay, look at this cavity here. Okay, let me put that a little bit. So you can see this cavity here. Okay, where there is no attachment of any muscle, but certainly this accessory gluteal muscle is going to run over that cranial part of the greater trochanter, and so that's why we need that bursa we just opened. Okay, we can see some synovial fluid there, as well as smooth shiny surface, which would reduce the friction as much as possible, and so that is your trochanteric bursa. So when you have animal falling on lateral side, this bursa may get damaged, and maybe after some time you may see inflammation of this bursa, and animal changing the posture to reduce the weight on that hind limb. Okay, usually it slightly like animal will try to lift up the one hind limb, and you can see that limbless, which is specific to the trochanteric bursitis. Also, you have the animal lying on the lateral recumbency. You work on something on the abdomen. You probably use your parallel fossa incision, but it went on for a little longer time, and then the bursa was crushing on the other side. If you don't have like good cushioning at the on the other side there, it might again result in the same thing. Maybe after a couple of days you might see those symptoms. Then you can certainly relate that to the lateral recumbency for a prolonged period of time. Maybe while walking, or maybe while in sports, you might hit the other horse, or you might hit the hard objects on that side. It might also damage the bursa. Okay, so let's come back to the ischiatic nerve and their further branches. Okay, so first of all, we're going to see the ischiatic nerve coming down here. As usually, it goes slightly caudal to the greater trochanter and then continues further between the hamstring muscles as well as between the heads of the semimembranosus. It continues further and splits into two major branches. So we have the common peroneal nerve, which could be now seen between the lateral head of the gastrocnemius and the cranial and middle part of the biceps femoris. And so that is your common peroneal nerve, which is also known as fibular nerve or common fibula, which will further split into superficial branch and the deep branch. Okay, I'm just pointing out the extent of both of them, either by means of their branches or their further continuation. The superficial peroneal would take care of the cutaneous innervation all the way up to the fetlock joint, and it is more involved in cutaneous innervation. We don't need to block that nerve. But there is other one, which is your deep peroneal nerve, which is branch of the common peroneal, which would innervate all the muscles and then further continue on the dorsal aspect of the metatarsal bone, dividing into lateral dorsal metatarsal nerve and medial dorsal metatarsal nerve. But remember, that innervates the fetlock joint structure as well, so we need to block that. Now, after innervating the fetlock joint, the same nerves, they continue further on the dorsal aspect of the digit on both sides. So here they are called lateral and medial dorsal metatarsal nerves. As they continue further on the digit, they would be called lateral and medial dorsal digital nerves. Okay, so that's regarding the common peroneal. The common peroneal, two major branches: superficial one as well as deep one. Superficial more involved in cutaneous innervation, deep one more involved in the innervation of the extensors of the digit and flexors of the hop, as well as deeper structures on the dorsal aspect of the pes, including the digit. Okay. Now let's come to the tibial nerve, another division of the ischiatic nerve. First of all, as it moves between, or it runs between the both heads of the gastrocnemius as well as superficial digital flexor muscle, it is certainly going to innervate all these muscles, as well as it will innervate the deep digital flexor. After innervating all of these, it continues further down, and you can see, I can locate that nerve right here between the DDF and the common calcaneal nerve. At this point now, it is going through the flexor canal of the tarsus. Okay. Same thing as we see behind the carpus, which is called carpal canal. But here it is not called tarsal canal, it is called flexor canal of the tarsus, which allows passage of the tibial nerve and splitting of the tibial nerve into two major branches, the lateral plantar nerve and the same one on the other side, medial plantar nerve. Where are they located? on both sides of the flexor tendons, and where they can be palpated, they can be accessed for blocking. Okay, usually you take reference of either head of the splint bone or the button, which is the distal end of the splint bone. Okay, so that is your lateral plantar nerve, which is branch of the tibial nerve, straight branch of the tibial nerve. Then we have medial plantar nerve, which is on the medial side, which is also another direct or straight branch of the tibial nerve. The lateral plantar nerve, as if I try to dig this one a little bit upward, I would see a branch coming from the lateral plantar nerve going underneath the interosseous muscle. Now, why does it go underneath the interosseous muscle? To give off the lateral and medial plantar metatarsal nerves, which would be responsible for nerve supply to the interosseous muscle as well as structures located deep to that. Means even the bones are usually innervated by the metatarsal nerves. Okay, so if I block the lateral plantar nerve well above here, then I'm going to block the deep branch as well, and I can block both of them. But usually we are not sure whether the branch is going to be given off or not. At that point, you're going to block the tibial nerve itself. By blocking the tibial nerve, you're going to block everything here. Okay, but also remember, blocking it here would also serve the branch, and it would also serve the analgesia of the interosseous muscle. Okay, that's why we perform that high 4-point block, low 4-point block. Then we have the digital block. Then we have the ring block here, here, or here. So if you consider your low 4-point block and high 4-point block, these are simply ring blocks performed at the higher levels. Okay, so let's come to the nerves, and then we'll discuss those blocks, at least with respect to the hind leg. Okay, so the tibial nerve split into lateral plantar, medial plantar. The lateral plantar is going to give off deep branch, which goes underneath the interosseous muscle to form the lateral and medial plantar metatarsal. Both of them, or the metatarsal nerves, they're going to end at the level of fetlock. They won't continue. But your lateral and medial plantar nerves, they're going to continue further, as right from here they're going to become lateral plantar digital nerve and medial plantar digital nerve on the other side. Okay, so that's regarding the nerve supply. Let's revise it in terms of nerve supply in the region of pes on the dorsal aspect as well as on the plantar aspect. Let's consider the dorsal aspect first. What nerves are present here? What nerve is located here? Not completely on the plantar aspect. Okay, and that's why it is called dorsal. We are on the lateral side, so that is your lateral dorsal metatarsal nerve, which would continue further as lateral dorsal digital nerve. Then we have medial dorsal digital nerve, which would continue further as medial dorsal metatarsal nerve, which would continue further as medial dorsal digital. Okay, which nerve gives off both of these branches? The options are deep peroneal or superficial peroneal.
Deep.
That's deep peroneal. Superficial peroneal, cutaneous innervation may be up to that point, but not below that. Okay. Now when you look at the plantar surface now, how many nerves are there? 2 superficial ones and 2 deeper ones. So we have medial plantar nerve as well as lateral plantar nerve, medial plantar metatarsal nerve located deep here, and we have lateral plantar metatarsal nerve. Metatarsals limited to that point only, while plantar nerves continue further as digital nerves. And remember, we have the dorsal branch. Again, which nerve gives off the dorsal branch? Either plantar nerve or plantar digital.
Plantar digital.
It is plantar digital which gives off the dorsal branch. So before it gives off the dorsal branch, we should call it plantar digital nerve. Okay, now let's look at the blocking. Okay, first of all, what we discuss is the digital nerve blocks. Could be performed as low as here. We can come slightly upward at this point as well, and then we can come up here as well. As long as it is performed below the proximal sesamoid bones, it's going to be called digital nerve block. It could be either distal digital nerve block or proximal digital nerve block. But remember, in any of the digital nerve block, you are not desensitizing dorsal part of the digit, as well as you are not including the dorsal branch. Okay, so what parts you are desensitizing at this point? You either desensitize this part of the hoof, or you desensitize everything from here below, or you desensitize everything from here below. But dorsal aspect is still sensitive, so if there is pain on the dorsal aspect, animal is still going to show that syndrome. So what do you do then? You perform the field block at the same levels. So somebody would prefer in that way. You perform the distal digital anesthesia, nothing happens, you perform the ring block at the same level. Then you do it slightly upper at upper level, you perform the ring block at the same level. And then you do even at the upper level, you perform the ring block at the same level. So you step by step keep desensitizing the part of the level. Then when you come up here, you're going to inject superficially as well as deep. Inject superficially as well as deep, as well as on the dorsal aspect. Okay, now tell me what nerves are blocked. Medial plantar nerve, lateral plantar nerve, superficial injections, deep injections, medial and lateral plantar plantar metatarsal nerves, deep injections and dorsal injections for blocking the medial dorsal metatarsal and lateral dorsal metatarsal. So everything from this point below is desensitized. Okay, but now consider if you have to perform, or if you suspect something wrong with the podotrochlear bursa or your navicular bursa. What block would you prefer? Now you're not sure, but depending upon the symptom that animal is showing, you probably suspect now it could be something wrong with the bursa. Let's see whether it is the same. Now which block would you prefer? The digital block, without any intervention on the dorsal aspect. Okay, because the bursa can be blocked by blocking the digital nerves. You can either perform, or you can either start right at the lowest possible level, that is close to the ungual cartilages, and then if the animal then comes back to normal posture, you say, yeah, that was the thing. Now you're going to do more investigation. You probably do with some sort of a geographic investigation, as well as then you might also try confirming your diagnosis by injecting into the joint itself or into the bursa itself. Okay? But once you localize that and you're quite sure, don't have to do that, because injecting into the joint would be the last choice, because we don't want to introduce any infection into the joint. We don't want infection into that. Okay? Unless it is extremely necessary, we should not introduce into the joint. Okay? So injection into the joint is not as routine as nerve blocks. But when it is not even found with the nerve blocks, then you can prefer going into the joint. Then we have no other option. Okay? Why it is done before we do any other thing? Because other things are quite expensive. Secondly, it would need more sophisticated infrastructure to use those new methods. Okay? You cannot just do CT or MRI in every single facet.
Yeah.
There. Okay? So you perform this first, and if needed, then you can say like, well, let's move that horse to some more, maybe university clinic or something, and then let all these things get done.